right, good morning, everybody. My name is Assistant Chief Ben Kaufman, and I'm proud to be the Chief of EMS for Montgomery County Fire and Rescue Service and lead the team of folks who are administering our brand new Whole Blood program. So that's Battalion Chief Pete Dugan and the talented EMS duty officers who are actually out there saving lives with Whole Blood. We certainly cannot do this without the recognition by the paramedics who are out running calls and seeing a need for patients who can benefit from Whole Blood, and certainly the folks who work behind the scenes to get this program up and running administratively. So today we're joined by leadership from Montgomery County Fire Rescue Service, leadership from Suburban Hospital, and leadership from Innova Blood Donor Services. This is a three-way partnership that's really brought this program to fruition and is out there, delivering care to the patients in need in the field. So today is going to run like this. We're going to have our Fire Chief, Corey Smedley, speak, followed by our Medical Director, Dr. Roger Stone, followed by the President of Suburban Hospital, Dr. Leanne Sedone, and then our Director of Innova Blood Donor Services, Nick Lilly. So the four of those people will talk individually, and then we'll be available to answer questions afterwards. I'll turn it over to our Fire Chief, Corey Smedley.
Good morning. As Chief Kaufman said, my name is Corey Smedley, the Fire Chief of the Montgomery County Fire and Rescue Service. Welcome to Montgomery County. We are really excited today to talk to you about a great program that has been implemented that saved lives. In August of this year, we implemented the Whole Blood program. Why is that important? I can tell you why. We're already seeing return on our investment of saving lives. When you think of what we do, we get a call for service, someone's in need, and then we have to have all the resources, all the certification, all the people to get there as quickly and safely as we can, and to mitigate that emergency and to help save lives. One of the great things that we're able to do is bring the right resources at the right time, and Whole Blood is one of those right resources. The bottom line is we can do what we call blood transfusions on the scene. You get the right amount of oxygen and nutrients in your system, and during a trauma event, that helps save lives, and we've already have seen that, and today we did an EMS award. Tomorrow we'll do our EMS awards, and we have Save Lives, and we will showcase that again tomorrow, where people walked out of the hospital and able to still be with their families. We, as Chief Kaufman mentioned, this is a partnership. It always is. It started out with making sure that our community is aware of these resources and educate them so that we can get additional resources from our public taxes. Our community Chief Administrative Office and County Executive Office helps us get the resources. We do the appropriate training, buy the appropriate equipment, and able to serve you on a regular basis. I want you all to know that every day, everywhere, your Montgomery County Fire and Rescue Service is reducing vulnerabilities in our communities, and the Whole Blood program is that. I'm going to turn it over to our Operational Medical Director, Dr. Stone, who will go into a little bit more detail about the program.
Thank you so much, Chief. Good morning, and again, for those who don't know me, I'm Roger Stone. I'm the Medical Director of the Montgomery County Fire Rescue Service. It's nothing less than an honor to address our internal and external stakeholders about what I think is one of the greatest milestones that we've achieved in my entire 24 years in the Office of Medical Oversight. So a perspective here, as we celebrate our 50th anniversary of advanced life support, which is synonymous with paramedics in the county, which is on the heels of the existence of organized EMS in Maryland since 1973, we're lucky to live in the state that is most nationally known when anybody in our line of work talks about a systems approach to EMS. As part of this framework, which is led by MIMS, the Maryland Institute for Emergency Medical Services Systems, the greater mission here with us in Montgomery County has not only been to meet the minimum requirements, but to exceed those minimum requirements for continuing to be an accredited state recognized EMS operational program. So to give you a perspective, I'd like to share some examples leading up to today of how we've worked to improve EMS care for the citizens of Montgomery County, particularly in the last decade. So I start with our push to become a heart-safe community, which back in 2003 led to congressional recognition for our response to cardiac emergencies. And at that time, it was best known for our STEMI program or our heart attack program at the time. Around the same time, we were one of the earlier national adopters of the Resuscitation Academy out of Seattle, which brought high-performance CPR to our management of cardiac arrest victims. This was quickly followed by our efforts at stroke mitigation and in support of our primary stroke centers. And as soon as the technology was available some years later, we modernized our intervention for large vessel strokes by referring our patients to comprehensive programs at Suburban and Adventist Shady Grove, with some other hospitals working on that capability even to today. In 2017, our mobile integrated health program was added to give us depth to respond to local needs and close healthcare disparities both before and after the 911 call. So that gave us tools to do more than just transport everybody to emergency departments. It gave us the ability to coordinate care to prevent the next 911 call. And that's what brings us to today, where we can make an analogous recognition of similar efforts when it comes to injury response and prevention in the county. So for many years, we in EMS were limited to only a few tools in the field when caring for the most severely traumatized patients. This was things like basic to more advanced airway management, intravenous access, and giving crystalloid fluids to patients to support very low blood pressures if they have dangerous degrees of bleeding. The reason for that being a limitation is with IV fluids, we're not replacing oxygen carrying capability, and the literature has been showing over the years that we may even bring some harm by diluting the clotting factors that are required to help stop the bleeding in the first place. So in the military, for some time, trauma surgeons have long recognized that there's a value to pre-hospital transfusion of blood as a vital life-sustaining bridge when patients are on the way to a facility where they can get rapid surgical intervention to stop the bleeding. So we've widely heard, even lay people have heard the press talk about the golden hour, which is that narrow window of time that EMS has to care for and bring patients to modern trauma care. But across the country, more than 100 million Americans live more than 100 minutes by ground from their closest trauma center. So it's estimated that in the meantime, many, many lives can be sustained or saved by EMS clinicians having access to whole blood for their critical patients. Nationwide, only about 1% of EMS systems have that capability. So we at MCFRS started taking a look at bringing this capability to the county starting about 2 years ago. By reviewing the medical literature. We attended meetings with colleagues across the country and brought some of those discussions to the county, then beginning to work closely with our partners at Suburban and Inova, who you'll hear from shortly. And in conducting data analysis, our excellent quality management shop estimated that by giving whole blood in the field, we could help save more than 40 patients every year with life-threatening hemorrhagic shock. But even that analysis didn't take necessarily into consideration some additional patients who have medical sources of bleeding that we could help as well. So around that same time, the Maryland State Police were giving us early reports of over 122 units of blood given to about 101 patients in the state helicopter's first year of operation with blood services. So at this point, I couldn't be prouder of the key multidisciplinary, multi-agency cooperation that went into the program, to include, again, our partners at Suburban Hospital's Department of Pathology and Blood Banking Services for blood storage, Inova's blood donation services for the sourcing of the whole blood, as well as Suburban Hospital's trauma program that we get to work with on a recurrent basis. And we should also fail to mention the various managerial and legal experts from our very own Office of County Attorney and the Johns Hopkins Medical Institutions, because there's a myriad of considerations, policies, procedures, and tasks that has to go into a well-balanced, well-oiled machine like this has become. So on August 8th, 2024, we went live, and we heard from our friends at the Pre-Hospital National Transfusion Coalition that they believe us to have been the 172nd EMS program, ground EMS program to do so. And within 8 hours of launch, we gave our first unit to a patient that became a survivor already. Our early experiences in these past 4 months have demonstrated the same promising results that we've been hearing about from our colleagues from across the country. Specifically, we've given 26 units to 24 patients as of Monday, but I hear that maybe there was a provision of additional unit overnight, so I have to check into that. I'd like to share just a couple of examples of cases that we encountered. The first was a person who had tragically been assaulted by stab wounds and who approached a firefighter to help that patient on the scene of a house fire. Now, the firefighter, who also happened to be a paramedic, was actually pumping water to the fire. That was the initial assignment, but quickly realized how sick the patient was, sort of jumped into action, beginning some life-sustaining treatment, and had the wherewithal, because the program was brand new at the time, to call for an EMS duty officer to give the blood, which helped stabilize the patient to bridge them to the transport to the hospital. Another case was earlier in time, one of our first, with a severe neck injury that was bleeding profusely, and the patient was on the verge of cardiovascular collapse. Again, a unit of blood was given by the EMS clinician and provided the necessary bridging and cardiovascular stability that allowed them to survive that injury. And there was even an example of something hitting home with our own MCFRS family, where whole blood was given to a colleague's relative who lives in the county and helped that person survive a fairly life-threatening medical source of bleeding. So as I get ready to sort of land the plane and pass the baton up to our next speaker from Suburban, I have to make a final point, which the chief began to allude to, about our innovations like this one, which speaks to one of the county's key visions for access to medical care and medical care itself. The Montgomery County way is to do its part to close disparities in healthcare access. Much like other new state protocols that are proffered by our agency in support of the health of vulnerable populations, example being our hypertensive disorders of pregnancy, which will take effect in July, whole blood is the quintessential example of an equal opportunity lifesaver. We'll continue in Montgomery County to always keep that in mind when we think about future medical innovations, and we're so proud in that respect that we are a just and egalitarian healthcare agency in the state of Maryland. As I see the podium to Leanne, I bring your attention to some equipment we have for the provision of giving blood to patients, which you can review a little bit later. And again, I can't be happier or over the moon to be talking to you about this today. And so thank you very much for being here, and we look forward to more life saves. Have a great rest of your morning, and I guess, Leanne, you're next.
Thank you. My name is Leanne Sedone. I'm the President and Chief Operating Officer at Suburban Hospital, and I'm joined here with my colleagues, Virginia Shad, she's the Director of our Trauma Program, and Dr. Norris Nolan, who is the Director of Pathology and Transfusion Medicine at Suburban Hospital. Suburban Hospital has been honored to serve as the community's Level 2 Trauma Center for decades. And with that designation, we have been so fortunate to have developed a long-standing relationship with Montgomery County Fire and Rescue Services. And together, our teams continuously look for ways to improve critical life-saving care to our community. And this Whole Blood initiative is just yet another example of that. Teams at Suburban Hospital Trauma and Transfusion Medicine worked closely with Inova Blood Bank and Montgomery County EMS to get life-saving blood to the scene of an injury and started for the patient while they are en route to the hospital. In these moments of severe hemorrhage, receiving blood as soon as possible improves a patient's survival rate. The Whole Blood program is a result of a year-long collaboration and planning with Suburban Trauma Services, and we admitted our first patient who received blood in the field on August 8th, the very same day the program started, less than 8 hours after the program started, and that patient survived. Since then, over 24 patients have benefited from pre-hospital transfusions. On behalf of Suburban Hospital, I want to thank Montgomery County EMS and Inova for allowing us to play a part in this very important initiative. I also want to recognize my team for their dedication and hard work to launch this program. And on behalf of the thousands of patients who come to us for life-saving care and the families who love them, I would like to express their deepest gratitude for giving them the very best chance at living another day. Thank you.
Good morning. My name is Nicholas Lilly. I'm the Senior Director at Whole Blood Donor Services. And I'm here to tell you a little bit about what we do and how we help to serve this important effort. So Innova has actually been within the community for the last 40 years. And Whole Blood Donor Services has been around for nearly 60 years within the community. We are actually the largest hospital-based blood center in the country. We service over 20 EMS partnerships, as well as nearly 20 hospitals and health systems within the area. And we rely heavily on the involvement of our community within Maryland, DC, and Virginia to help us to serve our patients. So this partnership is very key in our efforts. Again, to continue to support the community, and we can't do this without those members of the community. So I just want to thank everyone out there that helps host blood drives, helps by donating blood and spreading awareness about that. And again, we're very honored to be a part of this partnership between Suburban Hospital and Montgomery County. So thank you.
All right, that concludes the formal presentations. If anybody would like to come and take a look at the equipment we use during a blood resuscitation, you're welcome to do so. We'll entertain any questions, and I'll call Chief Dugan up to help show off our stuff. So thank you guys very much for coming. So far in Maryland, yes, there are several other MSOPs or operational programs that are working towards adding whole blood. Yeah.
Can you talk about what whole blood is and why it's important?
Sure. Maybe I'll let the doctor, you want to come on? Yeah.
So whole blood is a preparation of deliverable blood to patients' bloodstream that has all the components that more closely mirror the components of blood that are lost during the hemorrhaging process. Many other blood products are the result of a component therapy where you take the components of bloodstream, such as platelets or packed red blood cells and others, and give that to the patient when that is what the critical shortage is in the patient's bloodstream. Whole blood is the closer way of including components like plasma with the red cells and clotting substances that then replete the oxygen carrying capability and other capabilities of the bloodstream. So that would be the closest way of sort of answering your question about that. Is there anything else that you would add to? That's great. Okay. We have a pathologist with us who could elaborate. But yes, that's why we use whole blood. And further, in cases of assistance, a lot of people ask, O negative is considered the universal donor, and why do we use O positive? And the main reason is that something around 38% of donors have O positive blood, but only 7% is O negative or thereabouts, and therefore just supply, if we were to rely on just the supply of O negative, we wouldn't be able to replete our coffers of available blood. And because we use low titer, it's thought that some of the transfusion reactions that you can get by having positive, Rh positive blood given to negative patients, that risk is far outweighed by the fact that you don't have a chance of seeing that next day as you're in life-threatening hemorrhage if you don't get the blood now. So the risk-benefit ratio, clearly benefits low titer O positive blood, and that's why it's widely used. Anything else with that? Thank you.
I think you answered the question, but once again, the whole blood comes from donors, and is that where it comes from?
Yeah. So the blood starts at a donor service. So Innova Blood Donor Services will run a blood drive. They take the blood in. And the routing of our blood that we're using here is that Inova supplies blood to Suburban Hospital's blood bank solely for Suburban to hold that blood for us. When Suburban receives the blood, they'll notify our EMS supervisors. They go down to Suburban's blood bank, they pick up the blood, and then we keep it in the field for 2 weeks. After 2 weeks, we give it back to Suburban, and that blood can be used on another patient or broken down into components that Dr. Stone talked about. Sure. So I think it might be interesting to know that when we envisioned this program, it was about trauma resuscitation. We saw an increase in number of penetrating injuries, shootings and stabbings out in the field, and that was one of the selling points we used to actually adopt the blood program. What we didn't realize was the high volume of medical patients that we were going to be seeing and able to resuscitate with whole blood. So anybody who's bleeding, whether you're bleeding from an acute penetrating injury or an acute medical problem, think of a GI bleed or an obstetrics issue, you could need blood resuscitation for those reasons as well. And we're about 1/3 of our patients that are getting blood are medical and not trauma. Good. Okay. Great. Thanks. Come on up. Thank you, guys.
Test one.
Just talk through what we're doing. Oh, I got a microphone too. All right. It's on. Okay. Hey, yes, Lieutenant Will Tipton. Yeah, WILLTIPTON. I'm an EMS supervisor. I work at EMS 701. It's the Silver Spring area. All right. So basically, when we set up for a blood transfusion, we would have our medics on scene. They would get usually IV access, start an IV on a patient, and then we arrive on our EMS supervisor vehicle carrying the blood products themselves. So there's essentially a few components here. One, as you can see, obviously, is the blood itself, which would come in its own container. Then we have a bag of normal saline. That's just a normal IV fluid that's compatible with blood, so it doesn't cause any reactions when they're transfused together. We set them up on this life flow transfusion device, which has 2 ports, one for the blood, one for the saline, and then we would connect this through to the life flow handle. The handle here is basically what actually transfuses it. There's a syringe in here and a pump that's hand activated on here. That goes down to this part, which is a pressure reducer so that the patient's veins aren't overpressurized when the blood's transfused under pressure from the handle. And this goes to the, this is called the Q and Flow Warrior Light warming device. What this actually has inside of it is metal coils that heat up the blood. It heats it up to about 99 to 100 degrees, so it's slightly above body temperature when it goes into the patients. Very important to have blood at body temperature or warmer because hypothermia can be very dangerous to patients who are very sick or injured. And then that goes down. This would be the part that would actually connect to the patient's IV. So what we do first is we would close our blood and open our saline, and then we would actually pump through this. And so when we pump through, you'll see and this would return, and you just repeatedly pump like this. Each time you pump it, instills about 10 milliliters of blood or fluid into the patient. What we would normally do before we give any blood to the patient is flush this all with saline. Once that's done, you would close the saline portion here by closing this clamp, and then you would open the blood portion up. So then we would be prepared to actually give blood to the patient. So like I said, this gives about 10 milliliters at a time. A unit of blood is about 500 milliliters. With this device, we can transfuse per unit in about 2 to 3 minutes, which is very fast, much faster than if you were just to open this up and let it flow normally using gravity. And some of our EMS supervisors will carry 1 unit, 2 of them carry 2 units. And so sometimes patients require more than 1 unit. I think as they talked about, we've used blood 24 times, but we've used 26 units because we've had a couple of patients who required more than 1 unit of blood in order to be stabilized. So basically after we do that, normally we will always give the first unit while we're on scene with the patient to try to stabilize them prior to moving them. If we need to, we can transport them while we're giving a unit of blood as well. Then we have the, if we need the second unit of blood, we keep these all stored in our Delta cooler here, which basically maintains the blood at a safe temperature where it won't go bad. And that's what we were talking about when we work with our partners from Suburban Inova. Any blood that's not used and after 2 weeks is returned to them, and then they can use it further in their care for patients. And so far we've had, I believe, 0 units, correct? We have had 0 units that have actually been wasted, right? So far, I believe. Okay, and that's yeah. So, but very little loss to actual heat exposure from this, right? So we've had 0 units where it's been a issue where they got too warm and then had to be not used at the hospital. So that's basically the process there. We also have some documentation. We apply a wristband to the patient. And then we arrive, all of our EMS supervisors will actually go with the patient to the hospital, and we'll give report at the hospital to the receiving provider and to the nursing staff at whichever hospital they arrive at.
How did we come up with the name Whole Blood?
So that just refers, I think like Dr. Stone was talking about, this is blood that, essentially has been taken from a donor, and then other than having some of the RH factors reduced, it has been unaltered. So that's in comparison to usually if you went to a inpatient hospital, when they give a blood transfusion, they give what's called components, and those are red blood cells, platelets, plasma, whereas this is whole blood. This is the entire composition of one blood unit that's given at a time. Yeah, it's a good question. So all of our EMS supervisors, to begin with, are all lieutenant or captain at least, and so we've all been paramedics for an extended period of time prior to becoming EMS supervisors. And then specifically for the whole blood, we all do about a half day of training, hands-on 4 to 5 hours. That is hands-on using all this stuff. And that's the actual hands-on portion. In addition to that, we have several hours of online training that we complete with that includes, information on the background, the history of whole blood. And then we coordinate too, I think, as Dr. Stone and others talked about. There's other jurisdictions like Maryland State Police and Howard County who've done this, so we share some of our training information and resources with them, so we can all help learn through the process together. We're doing it, so in total it's I think between the hands-on and online portion, about 6 to 8 hours of training, and that includes not just with us. We have folks from the LifeFlow, from the manufacturer's company, who help train us on the devices and to use there. So it's a pretty extensive amount of training for it. Yeah, so the EMS supervisors are the only ones who carry the whole blood. So at any one time, we normally have a total of 6 units of blood in Montgomery County. We have 4 EMS supervisors, so 2 of them have 2 units, 2 of them have 1 unit. And so we are the only ones who do that, and then part of the process when we do give it is going with that transport unit to the hospital, in addition to the normal paramedic who'd be giving care for the patient. Sure, no problem.
Thank you for your time.